So which is most accurate according to the retrospective cohort studies on long COVID? And this is captured by several retrospective studies that non-white patients experience long COVID more often. B, more than 1 in 3 patients had one or more features of long COVID 3 to 6 months after initial diagnosis. C, long COVID has been more common among men than women. Or D, long COVID risk was highest among patients with mild to moderate COVID illnesses. So what do you guys think is the most likely answer to this question? I don't know how we could um, uh, um, yeah, I don't know how to do these polls, but someone had answered B and A or B. So it's very interesting that A is not right now. We don't have the exact figures. We suspect that long COVID occurs higher among people who are non-white, but um, looking at long COVID clinics throughout the country, the statistics are actually showing more Caucasians or engaging in long COVID clinic studies than all other populations. And so it's not men, it's women. If you recall my slide from 2 weeks ago, it was more women in the age of 40 to 60 years of age. And so if you click the next slide, the answer was B. More than 1 in 3 patients actually have experienced long COVID symptoms 2 to 3 months out past the acute infection time periods. And it's quite unique in that in terms of long COVID, more people will develop long COVID symptoms if they have been hospitalized or have been through the ICU. But that kind of makes sense to us because it could be it's just post-ICU sequela, or is it really long COVID? And that's really unknown. Most of the clients that we have that continue to be at our long COVID clinic are the ones who initially were part of the initial epidemic. And it's been quite sad to see that many of those individuals who were in the ICU still continue to struggle throughout the days. But again, I'm not sure if it's a long COVID effect or if it is due to just post ICU sequelae. And so the objectives of today is just for the local portion, unique demographic and geographic factors that influence acute and long COVID burden, and just for disparities across ethnic and socioeconomic and island populations. And the data remains limited to rural and Native Hawaiian communities. So next slide. This slide just shows just the disproportionate levels of people who are affected by acute COVID. And you can see that individuals with all groups, you can see Asians by far are the least, American Indians are the top, Native Hawaiian and Pacific Islanders are the second highest, and then Blacks, Hispanics, and all other groups. This was similar to what we found on the subsequent slide that I showed. So if you go to the next slide, our local data has shown that people of Native Hawaiian and Pacific Islanders, in terms of cases, hospitalizations, and death, are all greatly burdened higher than their African American, Asians, and white counterparts. And in our long COVID clinic, and this was at the initial phases of long COVID, more than half of the individuals were Native Hawaiian and Pacific Islander and Filipino compared to whites and non-Asian and other non-Filipino Asians. But when we look at how this has transformed in the more recent time period, the phases of our clinic has really changed. It has become more women, and it has become more Caucasians and Japanese actually. Perhaps looking into access to health, people who are have less, are working are less likely to come to the clinic, right? And so the face of the clinic has definitely changed in the matter of the past year or so. So next slide. And this is a slide on Dr. Gehan Devender's hospital fatality rates, and which was just accepted for publication in Emerging Infectious Diseases. And you can see that by far a large number of Filipinos, Japanese, and Chinese have a higher hospital fatality rate compared to other populations. And so on the more of the left-hand side, you can see Black, others, and whites are on the left-hand side, whereas on the right-hand side, seems to be a higher mortality, saying that more Asians have a higher hospital fatality rate. But if you go to the next slide, um, I'm sorry, just the when we look at if you adjust for the age, it will actually show that the individuals with higher age groups are or more likely to be Asian, and at the time to be disproportionate to be if you're older, you tend to be more explain some of that hospital fatality rates. And so when you take the younger individuals, those individuals will have a higher risk towards will be more of Hawaiian Pacific Islanders in the center. And so younger individuals will be more affected if they are Native Hawaiian and Pacific Islander compared to the Asians. And we just had a difference in effects of vaccination. The higher number, larger number of vaccinations resulted in lower hospital fatality rates, and that's not unseen from other data, other studies. Next slide. And so if you look at this slide, you could see that the biggest disparity often shows the no vaccination versus the vaccination. And you're looking at the relative risk, meaning the white. The highest white will be the biggest disparity between the two. And so you could see it in terms of Filipino Novax versus the wax. So blue compared to the orange. The biggest differences are the white portion among Filipinos, Hawaiians, and Pacific Islanders, meaning that there seems to be a bigger difference in terms of getting vax and non-vax in result in hospital fatality rates. So we believe that a large number of those individuals would be protected if they have been vaccinated, and that there are clear benefits of vaccinations among those populations. So we need to do a little better at trying to get populations to be more acceptant of vaccines and reduce their vaccine hesitancy. And I know that our colleagues in Waianae Comprehensive have done a tremendous job in reducing some of those barriers towards getting vaccinated with COVID. Next slide. And so our preliminary findings that there are definitely disparities of COVID hospital fatality rates among Asian communities. The reasons for these differences are still unclear to us, but we believe them to be biological and psychosocial factors, and definitely in terms of social determinants of health. And we're in the process of determining if the data collected on social determinants of health through the EMR can actually provide further insights into some of these impacts and the rationale of why there are differences in terms of these hospital fatality rates. Next slide. And so Hawaiian Native Pacific Islanders are disproportionately affected by at least acute COVID-19, higher prevalence of pre-existing conditions, diabetes, heart disease, some things that we discussed last week, and limited to cultural competence care of long COVID. Next slide. And so there are inequities facing post-acute care. Definitely there's uninsured and underinsured residents make it harder for them to get into clinics like our clinic in Queen Emma Clinics. I wish it wasn't the case, but it still continues to be a factor. And then crowded housing and multi-generational homes it may increase exposure risk. And Dr. Gihan Devender is actually looking into some of these issues in terms of getting housing, looking into housing and seeing if we could reduce some of these factors and kind of explain why some individuals continue to persistently have long COVID symptoms. The next slide. And then urban versus rural, that continues to be a big issue. Access to pulmonologists, neurologists, and rehab services continue to be an issue, even on Oahu. High transportation costs and time burden. With the advent of telehealth, that might be somewhat of a equalizer, although we know that technology is also limited to people who can afford technology, phones and such. Workforce shortages and long wait times, limited telehealth access, and then also cultural stigma and medical mistrust among groups. Next slide. And then so just the health disparities, which not only affect long COVID, but almost all chronic illnesses are affected by all these factors that limit and result in, unfortunately, the well-being of our clients. And then I believe that next slide is my last slide. So conclusions, race and ethnicity. Hopefully we can get to hear what this Saydah has to kind of inform us about where long COVID is actually clustered in the United States, especially among women more than men. Socioeconomics, we're not sure about the lower income communities. Again, access to these long COVID clinics can be a burden. And then age and healthcare access, and then the whole mental health burden on society. I think that's it for me. I didn't know, Melissa, is Dr. Saydah? Oh.
Thank you to everyone for your patience and understanding and my technical difficulties today. So I'm going to present on our public health approach to long COVID, present some estimates of long COVID in the United States and what we know in Hawaii, and talk about some lessons learned. Next slide.
Oh, 2 seconds.
So just
okay.
Sorry.
Go ahead.
All right. Disclaimer that these findings and conclusions are my own and don't necessarily represent the opinion of CDC. So for this talk, I'm going to talk about, go over how we can recognize the signs and symptoms and conditions of long COVID, talk about some of the estimates we have for the occurrence of long COVID in Hawaii and how it can be reduced, and equitable access to care for people living in Hawaii and CDC's efforts to address long COVID. Next slide. Oops, sorry. Okay. So long COVID is also referred to as post-COVID-19 condition or post-COVID conditions or post-acute sequelae of SARS-CoV-2. But in general, we refer to it as long COVID. And CDC is using the NASM, the National Academy of Science, Engineering, and Medicine definition for long COVID. And that's defined as a chronic condition that occurs after SARS-CoV-2 infection and lasts for 3 months. Long COVID can include a wide range of symptoms or conditions that may improve, worsen, or be ongoing. Next slide. So long COVID, there have been over 200 symptoms reported with long COVID, and these are the most common ones that we observe. So they include post-exertional malaise, persistent fatigue, difficulty concentrating, or what people refer to as brain fog, changes in memory, recurring headaches, lightheadedness, sleep disturbance, problems with taste and smell, bloating or constipation and diarrhea. So you can see these are all very common symptoms that people may have, whether or not they've had COVID-19. Many of these symptoms and conditions can last for weeks or months or even years. And most people, the good news is, do see significant improvements after 3 months. Many people experience more than one symptom, and many of these symptoms, while many are mild, many can also be severe and result in disability. Next slide. So in addition to the new symptoms that we observe, many people with long COVID also experience new or worsening conditions. And these can include system-specific diseases such as lung fibrosis, stroke, or diabetes, or some clinically significant symptoms such as brain fog and fatigue, as I mentioned before, or dysautonomia. And children often experience ongoing symptoms following MIS-C. And then this picture on the right just shows you the different parts of the organs in the body that are impacted. So it also affects chronic kidney disease, cardiovascular disease, and blood clots. Next slide. So as Dr. Chow mentioned, some of these groups, that we have observed a number of groups that are more likely to experience long COVID. Females are much more likely to experience long COVID compared to males. Older ages often more likely to experience long COVID, but this depends. So adolescents are more likely compared to younger children, and middle-aged adults compared to younger or older adults when we really are looking at new symptoms. But older adults are the most likely to experience new conditions compared to the other age groups. Those people who've experienced a more severe COVID-19 illness also are more likely to experience long COVID. So if you've been hospitalized, you're at a higher risk. And then those with underlying health conditions prior to COVID-19, specifically asthma and autoimmune diseases, also more likely. And then importantly, those who did not receive the COVID-19 vaccine were seeing an increased risk of long COVID. Next slide. So we do know that long COVID is a significant public health threat. Approximately 9.2 million adults and 0.3 million children in the US have long COVID. So these are results from our National Health Interview Survey. This is an in-person survey across the US where people are asked if they have symptoms that are lasted more than 3 months after having had COVID-19. And in 2023, we found that 3.6% of adults currently had long COVID, 8.6% ever had long COVID. Among children, it was significantly less than 1% currently had long COVID, and 1.4% ever had long COVID. But I think what's really important here is that even though some of these percentages might be relatively low, among adults who do have long COVID, 3 out of 5 report long COVID activity limitations. And among children, it's even higher. So among children who have long COVID, 4 in 5 children report activity limitations. Next slide. One thing is we have observed that non-Hispanic Asian adults, so these are groups that might be more relevant for the Hawaii population, are less likely to report long COVID compared to our other race ethnic groups. And however, the non-Hispanic, other, and multiple race category group has a high prevalence of long COVID. And again, these are estimates from the National Health Interview Survey, so they're for the entire US population. Next slide. We are able to look at long COVID by state. And this is data from our behavior risk factor surveillance system. It's a phone-based survey conducted in each state and territory. So it lets us understand the geographic differences in the prevalence of long COVID. And it uses a similar question to what we use for the National Health Interview Survey. So looking at these maps, we see the highest percent experiencing long COVID in West Virginia at 11%. And then the lowest percentage in the US Virgin Islands at 2%. In Hawaii, about 4.8% of adults currently report having long COVID. And of those, 14.8% are reporting significant activity limitations. Next slide. So as I mentioned, long COVID can, you typically resolves within 3 months, but it can also persist for a lot longer. So this slide here is presenting results from over 200,000 adults in England looking at the long-term effects of COVID-19. I like this because it goes out for up to 3 years after having had COVID-19. And we're also able to look across the different variant periods. So that blue line on the top is the wild type variant period, so early in the pandemic. And then the yellowish orange line towards the bottom is from the Omicron period, so kind of probably more recent, more representative of what we're observing now. In general, the mean duration of COVID-related symptoms was 1 to 3 weeks, and you can see that steep drop off on the curves on the graphs. And then at about 12 weeks, 7.5% continue to report ongoing symptoms. And then it continues to drop off. And by 52 weeks, about 5.4% report ongoing symptoms. And it looks like it kind of plateaus there going on to up to 3 years. Next slide. Well, it's been 5 years since the start of the pandemic. I think it's important to point out that we are still observing long COVID. And it's whether or not it's at the same rates is one of the questions. So this is data that was from a study conducted from the VA population. And they looked at the incidence of long COVID over time, compared the pre-Delta era, the Delta era, and then the Omicron era. And the line on top in red is among anyone who was unvaccinated. And then the green line, the solid line on the bottom, is among the vaccinated group. Here you can see that both in the vaccinated and unvaccinated group, the incidence of long COVID has decreased by about 1.75 events per 100 persons between the Delta and the Omicron errors. And that significantly reduced among the vaccinated compared to the unvaccinated. Next slide. So we know that among populations, conditions such as coronary artery disease and diabetes are highly prevalent among Native Hawaiian populations or other Pacific Islander populations. What has become clear is that COVID-19 itself can be considered a cardiovascular disease risk equivalent. So there's an increased risk of developing a major coronary event, such as MI or coronary death, over 10 years. And this is increased by about 20%. And it's similar to conditions like diabetes as a risk equivalent. Being hospitalized for COVID-19 therefore often represents the same risk for a major coronary event among adults. Among children and adolescents, COVID-19, compared to many other respiratory infections, has shown an increased risk of type 2 diabetes. So, and this is particularly true among children or adolescents who were either hospitalized for COVID-19 or who have obesity. And that increased risk ranges from 1.48% of 1.48 to 1.55 for an increased risk. Sorry, next slide. Just a bit discombobulated still tonight. I apologize for that. So as mentioned earlier, children do experience long COVID and many do report significant activity limitations. So these are results that are unpublished still, but they're CDC's results looking at the functional difficulties among school-age children with long COVID. So the gray bars are children who ever reported long COVID, and then the blue bars are those never reporting long COVID. And you can see that across every category, children who've ever had long COVID are much more likely to report difficulty in learning, remembering, concentrating, making changes, making friends, feeling anxious or feeling depressed. And all of these can significantly impact their ability to learn and to participate in activities. Next slide. For adults, the way that we assess the effects of long COVID is often looking at an individual's ability to work. So for this, we've used the behavioral risk factor surveillance system again, and there we found that functional disabilities and well-being, looking at well-being by employment status, by people who have report long COVID, and that they're much more likely to report a higher prevalence of cognitive disabilities, especially among those employed and those self-employed, and having depression. And these are doubled compared to what we looked at for pre-COVID-19 levels. So looking at prior to COVID-19 in prior periods. Among employed adults who've had COVID-19, long COVID also is associated with a higher odds of what we call presenteeism. So able to work, but have a number of work limitations or difficulty with memory or concentration, and with an increase in absenteeism. So more than 8 sick days a year reported. There's one report that looked at this among people in Hawaii, and that found that for people in Hawaii who reported long COVID, they were much more likely to be unemployed compared to those who did not report long COVID. In November of 2022, this was about 7% higher. Next slide. So I next wanted to just go over some of the clinical considerations with long COVID. We can actually skip this slide. So we'll go to the next one. Right. So long COVID, as you can imagine, it can be very challenging to diagnose clinically. There's no single diagnostic test that can tell us yes or no if someone has long COVID. And there are over 200 possible symptoms. So a patient might report many different symptoms that are related to many different body systems, making it even more complicated. These symptoms can also be, some of them cannot be easily explained by any objective medical testing. And so patients often feel misunderstood or stigmatized. And for clinical management, there's also not one management plan that has undergone extensive testing or has been proven to work in a clinical trial. So a lot of the treatment that we observe is trial and error at the individual level. Next slide. So what is important to remember is that the treatments should be tailored to a patient's specific symptoms. So these can include treatments that are FDA approved or over-the-counter medications. They can include holistic support for the patient throughout their illness, and this has been shown to be very beneficial. In general, healthcare providers really play a significant role in supporting their patients by validating their symptoms, recognizing the impact of the illness on the quality of life, and really completing a full clinical evaluation that's based on the signs and symptoms reported by the patient. And then healthcare providers can also connect them with additional care and service and support. Next slide. So the American Academy of Physical Medicine Rehabilitation has put together a compendium for providing comprehensive patient care for long COVID patients. And I know this is difficult to read, but I really wanted to present it just as a way to show you how they've organized this compendium. So they've organized it into these broad symptom categories. So what, like looking at fatigue or difficulty breathing or cardiovascular symptoms, and then listed many of the common symptoms that patients report and talk about some of the differential diagnoses and different possible treatments and managements for each of these. So it's a very practical guide that clinicians can use to consider different diagnoses for long COVID symptoms. Next slide. So we know that long COVID occurs, that affects all ages and impacts everyone, but really what we want to be able to do is reduce the occurrence of long COVID. Next slide. So the first question is whether or not Paxlovid can reduce the occurrence of long COVID. So if people receive treatment for Paxlovid during the acute COVID-19, does this reduce long COVID? And there have been a number of studies that have looked at this using populations from the VA, from Medicare, and from a voluntary citizen science cohort, and the results have clearly been mixed. In one study CDC did, we found that among adults over 65 who were treated with Paxlovid, there was a 12% lower risk of long COVID, a 7% lower risk among adults 50 to 60 years, and among the youngest group of adults, 18 to 49 years, there was also a 2% lower risk, but this really did vary by condition that we looked at. And we did not find any reduced risk among adolescents who were given Paxlovid. So for the younger adult group and the adolescent group, it's important to remember that Paxlovid there was really only indicated for those groups who had underlying conditions when they had acute COVID-19. Next slide. There has been a randomized trial looking at whether or not adults who are currently experiencing long COVID symptoms for at least 90 days and then were treated with Paxlovid, whether or not that reduced their symptoms. And the overall conclusion was that it did not improve symptoms. Both groups did experience an improvement in symptoms over time, which we saw when we look at just the trajectory of symptoms. Many people, their symptoms do improve over time as you go further out from the acute COVID-19 illness. But additional treatment with Paxlovid did not improve that. And it could have been that the treatment was not long enough since it was only 15 days. And so that's something that folks are continuing to look at. Next slide. The good news is we do have a lot of evidence that COVID-19 vaccination does reduce the occurrence of long COVID. So these are two studies from the CDC, one among children and one among adults, where people who were infected with SARS-CoV-2 and were vaccinated prior to infection, we found a 34% reduced risk of having one or more symptom among children and 48% reduced risk for children having two or more symptoms. And similar for adults, 24% reduction in symptoms for two or more symptoms among adults if you were vaccinated prior to having COVID-19. Next slide. We also were able to show that prior COVID-19 vaccination reduced the risk of many of the post-COVID conditions 6 months after SARS-CoV-2 infection. So this was looking at many of those newly diagnosed conditions such as GI disorders, respiratory disorders, renal disorders, circulatory system disorders. And on this, you can see that that risk is less than 1. So being vaccinated for COVID-19 protected those people for having many of these conditions in those 6 months after acute illness. Next slide. So I want to briefly talk about CDC's approach to long COVID and how we're thinking about this for public health. Next slide. So to approach long COVID, we really use the framework to guide our public health activities. So in this figure, one of the key component is surveillance and epidemiology. If we're not looking to identify who has the disease, it really doesn't exist and there's nothing we can do to address it. Once we've identified the disease, the next thing we want to do is really mitigate the impact for those who have it and prevent it for those who don't. And this can be done by linking individuals with care, with widespread prevention efforts like vaccination. For long COVID, it's also really important to combat stigma. So many people who are experiencing long COVID do not feel like their symptoms are believed, and so therefore public health strategies that can address the stigma and incorporate clear communication that long COVID is real can really help support individuals with long COVID. This also ties directly into public health agencies and groups' communications efforts that are focused around long COVID prevention and recognition and management. Next, it's going to be important to build capacity. This often falls to primary care clinicians. So understanding how clinicians can help their patients who are experiencing long COVID and support them with additional resources or engaging with professional societies can be helpful. And then we know that COVID-19 pandemic disproportionately affected many populations. So many of these inequities apply to individuals experiencing long COVID, and public health providers need to ensure that these marginalized communities are not the last in line to receive prevention or treatment or support services. And ultimately, to accomplish all of this, we need to build our public health capacity. Next slide. Actually, we can skip this slide and go to the next one. Great. So for CDC, we've really taken a multi-pronged approach in our surveillance efforts and efforts to understand the epidemiology of long COVID. So we've used cross-sectional health surveys, prospective cohort studies. We've tried to set up sentinel surveillance sites, and then we've used administrative claims or electronic health data. And each of these gives us a slightly different picture of what long COVID looks like. So what we get from electronic health data for new diagnoses tells us really information about people who are able to access the healthcare system and are getting those diagnoses. Whereas cross-sectional health surveys can tell us about people who are experiencing ongoing symptoms, and they're more likely to report their ongoing disabilities or functional limitations in those health surveys. And then the prospective cohort studies really give us an idea of how long those symptoms might be lasting. Do symptoms resolve after 6 months, or are they ongoing for a year or more? Next slide. So our long COVID surveillance strategies and approaches really present unique challenges to health departments. One thing is that long COVID, as going through those symptoms and conditions are all relatively common at the population level. And long COVID is related to multiple symptoms and conditions. It's not unique to having had SARS-CoV-2 infection, which makes surveillance very complex. We also are aware that state, tribal, local, and territorial health departments have very limited resources, which also limits surveillance strategies. Even so, some activities we're really promoting for health departments is to increase communication and engagement with clinicians to care for people with long COVID, expanding the awareness that long COVID does exist, and identifying different sources for data for surveillance. Next slide. So actually we can skip this one because I leave some time. So in summary, I just want to say that symptoms and conditions associated with long COVID are not unique to having had SARS-CoV-2 infection. We know that long COVID can occur following any infection and that anyone can experience long COVID. That clinical management of patients experiencing long COVID is very complex. But the good news is we do know that COVID-19 vaccinations prevent long COVID, and that more and more studies have shown that COVID-19 vaccinations prior to infection reduce this risk of long COVID, both among children and adults. Thank you.
Oh, wonderful. Thank you so much for that. Sorry about the technical difficulties. It looks like we do have a little bit of time left. Does anybody have any questions?
Yeah, could I? So thank you so much for being with us. We really are are appreciative of your time and your expertise in mapping out long COVID. One of the things that I noticed was that for long COVID, was there an overlay of the states that had the worst, like, West Virginia had the worst long COVID, and how do you explain those differences? Is there anything in terms of vaccination rates or social economics that may be at play as far as the states that have a higher rates of long COVID?
Yeah, that is a great question. And we thought the same thing when we first looked at that map. So we have a study that is unpublished right now. We're working on getting that finalized and submitted to a journal. But we took an approach to do an ecological analysis where we looked at the vaccination rates across different states, combined that with what we knew about the prevalence of chronic conditions in the state, since we know that having underlying conditions often increases the risk of long COVID also. And then also overlaid that with the overall infection rates for for SARS-CoV-2 in the states. And we did find that the states that had the lower vaccination rates and had higher incidence of SARS-CoV-2 were most likely to have the highest prevalence of long COVID, which is what we expect, but it's really driven by those two factors.
Thank you. And did I hear you correctly? So people who are American Indian or has a prevalence of a 6 versus Caucasians. I guess there isn't much of a difference between Hispanics, Caucasians, and Blacks in terms of long COVID. They were all around 3.8, 3.9, but the Native Hawaiians was very high. I mean, the American Indians were very high at 6. What explains that?
Yeah, that is a good question. I mean, I think one possibility is just that we know that there's a high rate of things like diabetes in that population, which puts people at an increased risk. They also, depending on the tribal nation, some of them did have very high rates of SARS-CoV-2 infections also.
And just a quick question.
Yeah.
Does ongoing more and more vaccinations, because right now 90 some odd percent of the populations either has natural infection or vaccinations through COVID. Does any more recent data show that additional vaccinations at this particular time offer any protection?
Yeah, I mean, I think the most recent data I've seen is, when we've looked at it, we've looked at vaccination in the past 6 months, and that still reduces the risk of long COVID. But we have not necessarily accounted for number of prior infections or number of prior vaccinations. Just, have you been recently vaccinated, yes or no?
Thank you.
Yep.
All right. Does anybody have anything else before we end this? You can pop on in or raise your hands.
Someone said, Shup, ounce of prevention is worth a pound of cure. Yeah.
Yes. Yeah.
I am astounded by the rates of cardiovascular equivalent. So having a history of long COVID puts you at the same risk of having diabetes. Is that right? Is that what if you have multiple risk factors? Would that change your overall equation for, say, Framingham in terms of the future or
Oh, yeah, that's a great question. I don't think we've really looked at it that way, but I mean, I think that is going to be an important question. That study that looked at that as a risk equivalent was also earlier time period in the pandemic when people may not have all been vaccinated or had prior COVID-19, and whether or not that changes if as your immune state changes is a good question too. Yeah.
All right. Well, it looks like that's about everything we have. Thank you, Dr. Chow, and thank you, Dr. Saydah, for persevering and getting on here. We really appreciate it. And then just so everybody knows, our next session is going to be August 12th, and it's going to be covering the cardiac complications in long COVID. So we'd love to see everybody here.